Welcome again to another episode of Smiles in the Air, your oral health and prevention podcast. I'm Celso da Costa, and today with me I have Dr. Devan Raindi. He's a British periodontologist qualified from the University of Birmingham. He won several awards as a student, including an award for the British Society of Periodontology. He completed this specialist training at the world-renowned King's College, London, graduating to a master's in clinical dentistry with distinction, and is a GDC registered specialist in periodontics. He's also the chair of the early career group of the British Society of Periodontology with a seat on the main council. He currently teaches postgraduate dentists advanced periodontal skills across the UK and is the founder of the Perio Coach, an educational initiative with a vision to promote excellence in the delivery of periodontal care. So, welcome to our podcast. It's a pleasure
Thank you, Celso.
to have you here. This time at a distance, so it's my fault. I need to say to the listeners, we always like to have everyone with us face to face. This time wasn't possible, but here we are. It's late at night, but I know that you finish a big day of practice, right? Because you are still with the scrubs.
I am, yeah. So it's been a busy day in practice, but no, pleasure to be here talking with you, Celso. So yeah, grateful for the invitation. Thanks for having me.
Yeah, thank you. So, Devon, tell me a little bit about your path. Why periodontology?
Yeah, I often reflect on that myself, actually. Halfway through the day, I think, well, what got me to this point here? And I think it all started off during my undergraduate training at the University of Birmingham. So at Birmingham, we had a very strong periodontology department, and I was taught by, world-renowned names in the field. And so I kind of my spark was ignited then, really. And my first mentor, Professor Chappell, anybody in periodontology will know him. Really kind of supported me at the start and gave me great advice and just showed me how interesting periodontology could be. And it just merged together a lot of different disciplines. It allowed me to combine the kind of physician element and the diagnostic element of being a dentist or a dental professional with the actual practical implementation and the advanced surgical skills that you can start to implement within your clinical kind of day. And then, yeah, once I left from the University of Birmingham, I just followed kind of a pathway. I just ticked boxes as I went through, did the years that I had to do, and then managed to land at King's College London, where I did my specialist training. And again, brilliant 4 years where I managed to kind of immerse myself with great leads within the field and come out the other end after many exams later.
And today you are inspiring your focus on minimal invasive non-surgical techniques. So how come? Because we know people that love perio, they love surgery.
Yeah, it's a good point. And yeah, I just mentioned, the reason or one of the things that attracted me to periodontology was the whole get your scalpel out and start cutting gums up.
Yeah.
And that was probably the my mindset. I couldn't wait to get out and do surgery, as much surgery as I could, until I would probably say halfway through my specialist training at King's College when Professor Luigi Nibali joined the teaching faculty. And as anybody who knows the field well will know, he's very much leading the way in terms of the academic side of minimally invasive non-surgical techniques. And so that started to make me just switch my thinking a little bit. And then when I left kind of my specialist training, I went into specialist practice. One practice was in North Birmingham, and the second practice was in central London, RW Perio with Rina Wadia, as you'll know. And a lot of my clinical practice in the central London clinic to start with was very much non-surgical in nature. So I kind of had to find a way to enjoy it because I was doing a lot of it. And as I did more and more of it, I realized the potential of non-surgical therapy because as the patients came back for their reassessments, I just didn't need to pick up the scalpel. And then we were starting to see significant improvements in bony infill, regenerative outcomes non-surgically. And so it really kind of switched my mindset. And because we'd built so many cases over the years, it really ignited my passion for it. And then, yeah, following that, I was invited to do a talk for the British Society of Periodontology on minimally invasive non-surgical therapies. That kind of really forced me to kind of
They were
think,
pushing
okay,
you.
what does the literature actually say about this? And then from there, it just all spiraled, and yeah, it was brilliant. And it also helps that I had all the right equipment for it as well. And I'm not just saying that because we're on the Smile is in the Air podcast, but for the last 4 to 5 years now, I've been using the EMS equipment, which has really helped as part of those protocols.
So you think also the equipment advancements push you to follow this path?
Absolutely. So I think if we look at the equipment in different ways, so first of all, if we look at kind of the actual physical element of the equipment, you've got the fine-tipped ultrasonics, which really allow for minimal soft tissue trauma. The technology, which the piezo technology, which ensures minimal pain and discomfort for your patients. All of these things combined ensure that, first of all, your patient is getting a comfortable experience. But second of all, as a clinician, I'm confident I am doing the job that's required of me biologically to allow the healing. And ultimately, as a clinician, that's what you want. You want your patient to be comfortable, and you want to be able to get the outcome you can get. And that's just a surefire way to build a good reputation and keep your patients happy.
Exactly. That's maybe the good word. The patient's happy. And you were saying before that you see that the patients are coming back and you don't need to get the scalpel anymore, or that you follow with the comfort for the patients, so the patients they are happy and they will be more compliant with your advice.
Absolutely.
That's the approach that you are having with the patients. That's what you are trying to make it happen. Is that the patient is compliant so you can have better results in the future?
Absolutely that. Absolutely. I think, I see many patients that have maybe previously had a not so great experience, and it's just put them off longer term coming back and having treatment. And that's why they've ended up back in my chair for active therapy. Whereas if I can carry out good quality care in a comfortable manner, that patient has confidence in the fact that actually this isn't going to hurt. This visit to the dentist or to my dental professional doesn't have to be a painful visit. It can be something that rather than I'm dreading, I'm looking forward to. And then what you can then find is, and we know with periodontal therapy, the active treatment is a very small proportion of this patient's journey. This is a chronic inflammatory disease. And I always say that chronic conditions have chronic solutions, okay? And it's a long-term game. So once we've got the patient as stable as we're going to get it, we will continue to see improvements in their supportive therapy regime. We've just got to make sure they keep attending it and they want to attend it. And that's what the equipment allows us to do or provides us with that luxury. So yeah, it's great. I can see patients 5, 6, 7, 8 year follow-up. And the fact I can get the 8 year follow-up because they're coming back to see us is the main thing. So yeah.
You said that you were seeing before you were seeing a lot of patients back in your chair. This means that coming from other professionals or your own patients, what is the main cause of having the patient back on your chair?
Yeah, so it's a good question. So generally, it would be kind of a patient that's maybe seen elsewhere and had maybe conventional or traditional approaches to therapy, a lot of scraping of the root surface, what we would have potentially called root planing, and they're coming in and they're saying, "I had my roots planed," and you're like, "Okay, wow." Even the patients understand this terminology, which is scary, right? So. But in terms of, I think it's a really good question because in terms of relapse in general, well, what do I find are the main factors for relapse? Well, I split them into different categories. If we start off at the kind of patient level, shall we say, and the kind of systemic level, you've got general risk factors like smoking, which will increase the patient's risk of relapse, for example, undiagnosed or uncontrolled systemic diseases. So diabetes is probably one of the big factors. If we have patients that are poorly controlled diabetics, we tend to find that they will relapse or demonstrate some form of progressive attachment loss compared to those patients that are much better controlled. And then in terms of the patient behavioral factors, it's their compliance as well. There are patients that I will have seen that maybe I've done the treatment, the active treatment, and then they've gone off and traveled the world or etc. And then they've come back and they come in a little bit embarrassed, tail between their legs, saying, actually, I haven't followed up on my compliance as you asked me to. And we see that maybe there is some relapse in those cases as well. So patient compliance really important. Patients' oral hygiene, their level of plaque control. This is something that during supportive care, we're disclosing, we're remotivating these patients. If they're not getting that remotivation and they're not carrying out their ideal home care, that will increase their risk of relapse. And then you've got the kind of site-specific factors. So things like, overhanging restorations, for example, or furcations, things that can act as plaque retentive factors at a site-specific level can potentially cause relapse as well.
So this is what I love. Like you have full package solution, because you were talking about the technology, but now you said two aspects that are really, really important. One is patient compliance, and another one is information that you are giving to the patient. So first of all, we are educators, and to solve periodontal disease, we need to inform the patient, we need to prepare the patient for the worst too, and then finally we will try for the best. Yeah, sure. So that's where we get in with the protocol, maybe because we are getting guided biofilm therapy, because it's not only centered on the equipment, but it's centered also like do your assessment, explain to the patient what they have in the mouth, motivate them based on their needs. Then we do the treatment, and at the end, repeat. So what have you found? What's gonna be the next recall? Why we have the next recall? What is adapted for you? So how you see this as a full protocol?
So the guided biofilm therapy
Yeah.
protocol. So yeah, so I do like protocols in practice. We've got to remember that we are clinicians. There's that fluidity of treating patients and adapting to patients. But if we have an overarching kind of concept that we're working to, because I always split it down into the concept, which is ultimately resolving the disease. So removing the biofilm. Biofilm's the cause, we have to remove the biofilm.
Yeah.
With minimally invasive non-surgical therapy, the other element of the disease process is ensuring that we've got a stable wound, because that promotes regenerative outcomes compared to reparative outcomes. That's where you get minimal attachment loss, minimal recession, and bony infill. So they're the concepts that we're aiming for: biofilm removal and minimal soft tissue trauma, which allows for optimal wound stabilization. You've then got the technique by which you do this, okay? And if we're going to break that down to the next level, this is what I consider minimally invasive non-surgical therapy as a whole, okay? And then based on that, it's how exactly do we carry out minimally invasive non-surgical therapy? And that's the protocol which you carry out. And that's where guided biofilm therapy is an excellent example of carrying out minimally invasive non-surgical therapy. Okay, so it just adheres to those principles that allow for optimal biofilm removal by the patient and by the professional. And then second of all, it will allow for optimal wound healing because we're using the right equipment that causes minimal damage to the tooth structure, first of all, and then the soft tissue following that. So for me, that's one of the main things that I really like about it. And then second of all, I work with a team of hygienists and therapists in the UK, and being able to a degree, standardize that element of care, knowing that there is a protocol in place where they follow the steps, albeit adapt it to each patient. That provides kind of reassurance that the patients are getting a consistent standard of care. And also it provides the hygienists and the therapists with kind of an infrastructure within which they can work and improve as well. So yeah, that's why I hope that answered your question.
Yeah, it
Yeah,
was a good answer because I like what you said. Like we have a structure, but we are clinicians, and clinicians we need to adapt to the patient needs. So yeah, you have a protocol. Then based on this protocol, you have the frame, and based on the patient, you will apply this frame more or less based on their needs. And the second thing that I loved, because I use this example a lot, the periodontal disease is an open wound. It's true. Like if you have an open wound on your arm that is bleeding all the time, you're gonna be worried and you're gonna treat it. Same thing happens in your mouth. So you have bleeding gums, you have open wounds, you have inflammation, so you need to treat it. How? Well, consult your clinician, and they will, based on your needs, they will give you the best care as possible and the best advice.
absolutely, absolutely.
So, but how you envision the future of minimal invasive periodontology?
That's a really good question. So I would I would split it into two. So
Hmm.
minimally, and it goes back to what I said before. You've got the two concepts of minimally, and no understanding and knowing your why. I always say allows you to progress and evolve the technique or your therapy. So if we go back to our why, we're removing the biofilm, right? That's one area where we've got to look at future innovation. And then on the second hand, we're promoting optimal wound healing, which allows for regenerative outcomes. So in terms of the future of biofilm removal, well, I think we're not doing a bad job already. We've got the equipment that we need. First of all, the fine-tipped ultrasonics, the air polishing powders that are so minimally invasive now, you can use them on soft tissue. So really huge advancements have been made in biofilm removal. I think going forward into the future, it was going to be great to see how things progress in terms of microbiome manipulation, and really personalizing the dentistry from that side of things. So that could be quite an interesting element to the future. And maybe also techniques in which we can optimize removal of the biofilm. So visualization techniques. There are things like endoscopy or other things that could come to market that could optimize the biofilm removal. Where I'm seeing the literature start to advance at the moment is looking at the wound healing side of things. So we know we've got the wound and kind of this biomodification of the wound to allow for the regenerative outcomes. It could involve the application of biomaterials, for example. So if I can give you an example, in regenerative surgery, we use a material known as emdogain, which is an enamel matrix derivative. It has a huge range of mechanisms by which it kind of promotes regenerative outcomes. Now, a novel way of applying it, in fact, it's not even that novel, it was described many, many years ago, but it's coming back into vogue now, is after you've done your non-surgical debridement in a minimally invasive fashion, so you're keeping your soft tissue structure intact, you apply the emdogain non-surgically, and by doing so, you're kind of manipulating the wound to promote a more regenerative response. So you're getting less recession and more clinical attachment gain. And there's research now demonstrating it, albeit with secondary outcomes, that the use of these biomaterials could provide benefits in greater percentage pocket closure, greater percentage or greater improvements in clinical attachment level, for example. So that's an exciting area, whether it's enamel matrix derivatives, whether it's hyaluronic acid, which is described, PRF. There's a whole range of different biologics it opens it up to. But yeah, that could be the future. Who knows?
I'm proud to say, like 7 years ago, I have done a study with Pedro Gonçalves. At the time, was it Strauman, and I was invited to be the one doing the non-surgical periodontal treatment and apply endongan. And so I was part of some of the trials of these studies that with really good results, actually. So, but yeah, yeah, sorry.
I was just saying that's fabulous. You're 7 years ahead of me, Salso, honestly. So, I mean, we just published an article in Dental Update. It came out, I think it was about a week or 2 weeks ago. It was a simple case report on the use of enamel matrix derivative, Emdogain, but we got quite positive outcome. And then we discussed the literature that's up to date. So, but yeah, no, it sounds like you were, yeah, you're ahead of the game.
No, but the funny thing is like we have done this 7 years ago, good results, and then the final answer was always the same, but it's too expensive. And but you think like can you put a price on the health of the patient? Can you put a price of like avoiding surgery? And that let's be honest, when you have surgery is not a given. Also, it's not free. You need to pay it, and it's a lot, and you have the recovery time. And living in this fast-paced world where everyone wants to solve everything so fast, um, we know if we gonna go get the scalpel, like you said in the beginning, and open it, it's gonna take longer just to heal. So
Absolutely.
how
Absolutely.
how you see this approach? How
Yeah, I think, surgery for, I say now, surgery for periodontitis, having gone through specialist training and years of kind of education and exams, I very rarely do surgery for periodontitis. And the reason is the non-surgical works just so beautifully well. Okay. It's very rare to have to pick up a scalpel for periodontitis. I still do a lot of surgery, maybe cosmetic grafting, gum lifts, etc. Sadly, you can't do that non-surgically. But in terms of surgery for periodontitis, very, very minimal because the non-surg works so well. And it goes back to what you say. That's a huge benefit for the patient at a whole different number of levels. First of all, the most obvious being the morbidity side of things you mentioned. The downtime. Surgery is not a nice word. If you put on one plate to the patient, we're going to be doing surgery on you, and then you put on the other plate, we're going to be doing minimally invasive non-surgical techniques. I would be very worried which patient would actually pick this plate over here.
yeah.
It sounds better to the patient. It works better for the patient longer term. And then aside from the morbidity, you touched upon the cost effectiveness of it. And, even before picking up your ultrasonic to do the subgingival debridement, actually educating the patient, it goes back to what you said about education. Educating the patient, disclosing them, showing what the problem is actually the most cost effective, in my view, treatment you can provide that patient and actually the population in general. And The Economist showed that, managing gingivitis is much more cost effective than the kind of downstream treatment approaches, be it even non-surgical or surgical. So we need to be working right upstream for patient morbidity and also for cost effectiveness at an individual and population level. So yeah, agree with you completely on that.
Yeah, fully agree. We are in agreement here because we are being seen as we are oral health professional. On this oral health profession, there's health, but by the patients and maybe by the society in general, we are seeing as disease solvers. So we are doing our job based on the disease instead of being doing it based on the health, and this has its costs for the national health system, for sure. But it has also this cost in terms of the health and the quality of life of the patient. Because when we are treating perio, most of the times we are treating is already too late. We lost bone. Then, like you said, even if we solve it, we stabilize, then we need to have the static procedures. And not to consider the health, the systemic health of the patient. Because you know this, and you can explain here now the correlation between a diabetic patient and periodontal disease, cardiovascular patient and periodontal disease. So it has also these effects on the quality of life of our patients.
Absolutely agree. So yeah, and I think it's something that actually I think the periodontal community is very good at actually. The research in systemic impact of periodontitis is exponentially increasing. It's been exponentially increasing for many years now. I think the main challenge has been ensuring that research has disseminated out to first of all, the professionals that are talking to their patients in the dental surgeries or dental clinic, And I think that, particularly in the UK, dentists and hygienists and therapists are very good now at understanding that and discussing that. I think the real challenge, which again we're seeing movement forward in, is getting our medical colleagues to really sign up to that as well. And historically, the specialist communities, kind of, the diabetic specialists, the endocrinologists, the cardiovascular specialists, very good. They had joint consensus workshops. We're talking 5, 6, 7 years ago, even. So that discussion has been happening at that level. But I think it's disseminating that through to the family doctor or the general medical practitioner for the individual, which is probably the next step to secure it. And that's happening. There's been workshops on that very recently, the Wonka workshop, which was completed very recently. So guidelines have been made. And in the UK in particular, we are seeing medical guidelines now mention the importance of treating periodontitis, particularly in diabetic patients. Ensuring that diabetic patients get a screen with a dentist. There's a commissioning pathway for that. And ensuring that patients are aware of the risks that diabetes poses on their periodontium. So we're getting there. It's a slow game, but I think we're getting there.
I think so. Because periodontal disease is such a multifactorial disease that and it's still funny as we still get impressed by find out that an Alzheimer patient, well, the bacteria that we find in oral biofilm we also find in the brain of an Alzheimer patient, and for me this is fascinating, but at the same time is also kind of it makes me scared, right? Because we still think that maybe it's not possible having a bad oral hygiene is it's okay. Having bad teeth is a family thing. We still see this a lot, mostly when we are treating patients and hearing their stories and saying, "Yeah, no, I just have this because I just didn't brush my teeth half an hour ago. I had just breakfast," and you have the disclose and say, "No, finally, it's been some days that you have this biofilm. Look, there's inflammation. If I touch here, you have some bleeding." And this happened. I'm not joking, not joking. I had a patient that was a patient neuro uh, he was working the neurology department in a big hospital here in Switzerland, and for him was kind of a finding that he had periodontal disease, that this could be a problem that will be influencing other systemic health problems. So it's going slow, but it's scary how even health professionals in other areas do not find oral health important.
Definitely, definitely. And in my own practice, I see a lot of doctors, and when I'm sitting down and part of my consultation or assessment is discussing their findings and explaining everything. What I used to do is I used to make an assumption. I'm talking to a medical professional. I can kind of swift over some of the simple terminology and actually when I went back and I said to them, look, you've got gum disease. What do you know about it? And I give them an out. You can say nothing at all, and I'll start from the beginning. Most of the time, they were saying, "Look, we got a half an hour or an hour long lecture at medical school about this, and let's face it, I haven't revisited those notes ever since. So let's start from the beginning." So I think that there is an element of kind of policy when it comes to periodontitis for any form of periodontal disease, where incorporating the education into undergraduate medical teaching and postgraduate medical teaching, where the responsibility also lies with us as clinicians, engaging with our local medical teams, engaging with our local hospital departments, so we can provide our expertise. And 'cause what happens is when I do discuss it with them, they are actually very engaged. They're very interested in it. So it's just engaging with them, isn't it?
It is, and well, we need to touch some of these health professionals so we can spread the word. And if periodontology is what it is today, and is maybe one of the most fascinating areas, at least for me, it is in dentistry, and we can see that it has such a power of influence on others because no one gonna place an implant on a perio patient, or no one will make some aesthetic work or orthodontics in a periodontal patient without solving it first. Is because people like you are so passionate about it, want to make the difference, and to want to keep the smiles of the of our families and friends for a long time. Devon, what kind of advice can you leave for well, most of the people that listen to the podcast, they are young clinicians, fellow colleagues. What kind of advice do you want to leave here? Maybe to push someone to follow your path in periodontology and to follow this minimal invasive non-surgical approach.
I mean, generic advice, I would say, if you have any instinct in what your passion is, it really just pursue it, follow it. It's finding your passion, which actually can be quite a difficult thing. I was very fortunate to find mine early on. And on that note, I would say surround yourself with individuals that share your passion. Because if you can surround yourself with the right community and network, that really is what gives you the energy to turn up every day and make it all worthwhile, because you're going to have some good days, some bad days, but if you've got that community to draw upon, it makes that journey so much easier. And then in terms of minimally invasive non-surgical therapy, what advice would I give to people from that side of things? Get good at it, because it's the future. Put the scalpel down, pick up the ultrasonic, and get good at it, because really your patients will thank you. It's really rewarding seeing the improvements you can make on a patient that you haven't had to cut up. And yeah, I think that's really what I would recommend. But yeah, find your passion, surround yourself with good people that share that passion, and that's really a recipe for success, I think.
It's funny, right? Because non-surgical seems so easy, but to do it right is super difficult.
I always say, I say that non-surgical therapy for periodontitis is harder than surgical therapy for periodontitis, because once you can raise a flap, you're just looking at the root, so you can look at it, you can see the root surface, see what you've got to
Yeah.
remove, right? But
Yeah.
non-surgically, there's this thing called the gingiva that's covering it. And then you've got to negotiate the grooves and the furcations, and you've got to have knowledge of that. And then you've got to look at the radiograph to try and manipulate your way around. So really, there's a lot of challenges. And then you've got the patient on the end of it. Um, so,
Yeah.
um, so yeah, I always say non-surgical therapy, and my mentor, Professor Chappell, told me the same thing, is infinitely harder than raising a flap and just removing what you see.
It is, there's it's funny. I don't know if it happened with you, but with me it happens sometimes when you have a super difficult patient that you are subgingival. So I close my eyes just to feel it better, like just to feel the furcation, the anatomy of the root, where I am, if I'm doing the right movement. Oh, this is a different sound. This is a different feeling. Here it is. Remove it. So I don't know if it happened to you, but with me it happens quite often.
Absolutely, yes. It's and then your patient's thinking, are you meditating halfway through the treatment?
Yeah.
But it's absolutely, yeah. It really helps it really helps with the tactile sensation. So yeah, really good.
Devon, thank you so much for coming to the podcast. It was a real pleasure. And having passionate people like you is always good for me too, as a motivational side, personal side. So thank you once again.
No, it's been my pleasure, Salso. Thank you for inviting me again. It's been a pleasure to talk to you this evening, and yeah, hope to see you again soon.
Yeah, yeah, for sure. For all the listeners, thank you so much for listening to this episode. Follow the passion. That's surround yourself with people that really want to share the knowledge. And minimally invasive technique is the present and the future, and it's difficult to do it. Do not forget to subscribe our podcast in any single platform that you listen to us. Can be Apple Podcasts, Spotify, or even at YouTube. So subscribe and don't miss the next episode. Thank you.